I read this 2025 clinical trial from researchers at Vanderbilt University and the University of California, San Diego, so that you don't have to. The purpose of this study is to test how adding a sodium glucose cotransporter 2 inhibitor and a glucagon-receptor antagonist to standard insulin therapy affects adults with type 1 diabetes. Let's quickly define what these two drugs do. A sodium glucose cotransporter 2, SGLT2 for short, inhibitor lowers blood sugar by blocking the kidneys from reabsorbing glucose, so more glucose leaves the body in urine. A major benefit of this drug is lowering blood sugar levels in people with type 2 diabetes. A glucagon receptor antagonist blocks the effects of glucagon, the hormone that raises blood sugar. A major benefit of this drug is that blocking glucagon can lower the liver's glucose output, which may improve blood sugar. The hypothesis of this research is that combining these two drugs with insulin will improve blood sugar, reduce insulin, and lower ketones in adults with type 1 diabetes. But how did they test the hypothesis? The researchers enrolled 12 adults with type 1 diabetes. Each person went through 3 different phases: their normal insulin therapy, insulin plus an SGLT2 inhibitor, and insulin plus both the SGLT2 inhibitor and the glucagon receptor antagonist. During each phase, they collected continuous glucose monitor data, measured insulin doses with insulin pumps, and ran something called an insulin withdrawal test. Here's what they found. The combination therapy performed the best overall. Average blood sugar dropped, time and range increased, and people ended up using about 27% less insulin than in the insulin-only phase. Participants even reported higher satisfaction with the combination therapy. This clinical trial was clear, easy to follow, and the researchers were transparent with their data. The results were genuinely promising: better blood sugar, more time in range, and lower insulin needs. But I do have some concerns about the direction this research is taking. Blocking glucagon raises questions, since glucagon is a life-saving emergency treatment for severe lows in people with type 1 diabetes. Also, adding more medications on top of insulin feels like treating symptoms rather than addressing the core issues of beta cells not making insulin. For this, I'm giving this paper a 4.7 out of 10 on my completely made up type 1 diabetes research score, which puts it in 6th place among all the studies I've reviewed so far. There's a link to the full article in the description. I recommend reading this one. Special thanks to the researchers for keeping it publicly available. If you're interested in type 1 diabetes research, subscribe for more.